2nd of February with complaints of fever since 1.5 months before admission and 2 episodes of paroxysmal events. Child was normal until 1.5 months back, after which she developed fever, which was 1 to 2 spikes of moderate grade, undocumented, nearly every day, subsiding with antipyretics. Child not very active throughout those days with generalized fatigue, for which she was taken to local practitioner, received multiple antibiotics and other symptomatic treatment with no significant improvement in fever. Fever was not associated with headache or abdominal pain, persistent diarrhea, joint pains, vomiting. On 16 January, approx after 1 month of the fever onset, she had one episode of paroxysmal event in the form of uprolling of eyes, tonic-clonic movements of all four limbs with loss of consciousness associated with fall, lasted for 1 hour, for which taken to a nearby hospital. She was intubated and started on multiple anticonvulsants. She was extubated after 1 week, conscious oriented, responding normally, but required assistance to get up from sitting position and to walk. This weakness gradually improved over time to independent walking. She was investigated for the same and was started on some oral medications. 12 days later, 12 days after the first paroxysmal event, she had another episode of paroxysmal event in the form of uprolling of eyes, only preceded by getting scared by the death of another patient in the neighboring bed, lasting few seconds and subsided on own. After this, post this, mother noticed change in her behavior in the form of decreased responsiveness, like not answering questions, not obeying commands. Also, child complained of seeing some people around her and hearing some strange noises. For this, referred to our hospital for further management. On further questioning, mother complained of child having rashes all over body, small sized, non-itchy and pale colored since few months. Also gave history of hair loss in the form of many hair strands getting stuck in the comb while combing hair. History of loss of appetite and weight in the form of loosening of clothes since the onset of fever. No history suggestive of any cranial nerve involvement. No history of abnormal movements or sleep disturbance. No history of erythematous rashes or rashes over face. No history of abdominal distension or pain in abdomen. No history of decreased urinary frequency or red colored urine. No history of any severe infections requiring hospitalization. No history of any COX or COX contact. Family history, no history of any hospital admissions till 2 months ago. History of skin lesions over left upper limb 2 years back, which subsided with treatment after 3 months. Rest, birth history, family history is normal, vaccinated according to NIS schedule. Developmental history, milestones are achieved appropriately for age, and socioeconomic status upper middle class.
You all come here so that there's only one fan also. AC is not working. Come in the first row also so that you don't feel hot also. Okay. So now, overall, tell me what is your analysis of this fever? Means I want you to describe this fever in 1 or 2 sentences using adjectives, which will give you the analysis of the fever.
It's persistent fever with.
So one is persistent fever, very good. Then?
Non-progressive.
Okay, so by non-progressive you mean that the trend or the progress is the same. Okay, not worsening. Then?
And not responding to,
Not responding to? Specifically, antibiotics. Then,
No localizing.
no localizing signs. Very good. And one more important thing which is there. Interfebrile is what?
The child is not very active.
Okay.
Not touching the baseline
Okay.
temperature.
And how stubborn is the fever? Is it 24 hours a day?
1 to 2.
1 or 2 spikes a day. So now you add all this, what does it tell you?
Non-infective in origin.
Okay, so you think it is likely non-infective. Okay, so there are many points against bacterial. It has not responded, it has not worsened, 1 or 2 spikes a day, fine. Can it be any bacterial? So chronic bacterial, you'll keep in mind. So what are those other symptoms suggestive of? Where she is not good, interfebrile, what are they suggestive of?
Some form of activity is ongoing, some form of inflammation.
Chronic inflammation. So there is some form of chronic inflammation going on. Okay. So now if you club everything, one you said is non-bacterial. So in non-bacterial what?
Inflammatory.
So one is inflammatory diseases, autoinflammatory rheumatic diseases. Anything else?
Malignancies.
Malignancy and chronic infection. So these are your 3 broad groups. Now you can further try to put them one above the other, right? Then, okay, then come to the seizure. What does the seizure mean? Look at the features of the seizure and then decide. So first time seizure probably, because there is no past history. First time seizure, if it is a very prolonged seizure like a status, does it have any significance? So here, of course, this is after 1 month, but Udani sir always says that when you have a first febrile status, like first time seizure ever, and it is a febrile status, there is more than 95% chance of it being CNS infection. Okay, of course that is, so what you have to understand it properly, that it is with fever, it looks like a febrile seizure but is a status, first time ever. And that is very, very high chance of infection. This is not that story, but I am just bringing that point. And okay, then after that, so this last 3 lines mean what? Was there a motor deficit, do you think? What do the last 3 lines mean? Was it a motor deficit like a paresis or something?
I think more likely it was post recovery, post infection, extubation. She was taking time to get fit.
So it's not definitely paresis of any kind, but generalized weakness. Okay? Yeah. Sir.
I think when you look at the whole story, the diagnosis becomes simple. Okay. But look at the first 2-3 lines. They went to a doctor and who gave multiple antibiotics. That is what we should not be doing, and that is what we want you to learn. Otherwise, finally, this child is still living, and this child will get better. But see how the problem has been worsened. So if you were there right on day 2, day 3 of fever, you have two clear things. We do not know by that time progress, that it is static. Okay, but we know enough that there is no localization even on day 3, day 4. And in between, look at what the whole story said. Child not very active. Okay, who is active? When we say interfebrile period, we want to know whether the child at the peak of fever and at the trough of fever looks different in behavior. And what is that behavior? I like to sit, I like to watch TV, I like to talk to my relatives, I like to eat something. That's the behavior. On the other hand, no, don't talk to me, let me lie down and let me sleep. That behavior. Weakness everybody gets. So even at that time, on day 3, day 4, you have no localizing symptom and interfebrile period doesn't look to be sick. But you had to ask many more questions. And at that time you would have said it's unlikely a bacterial infection. Of course, not an infection at all, no viral infection at this age, without a contact. So straight away on day 4, day 3, okay, we go to an extent of saying it in day 2 also. The rhythm of fever, look at that, 10 to 12 hours, which is the natural rhythm of a disease and not due to paracetamol. Enough to know that this is non-infective right to begin with. How powerful is the detailed history and the analysis. Okay, so to begin with only know, tomorrow Archana's video will be on our steer. She's talking about PUO, and the following Tuesday I'm going to sum up about how to approach fever. But in this child, this is exactly what she was trying to say, that in the first 4 days and sometimes up to 7 days, you must get a diagnosis of a group. Infection, no infection. Okay, here we could have got it on day 2, day 3. So that is one. But look at the second part of it. The seizure come at 1 month after the illness. Could it be my analysis is wrong and this is a bacterial infection to start with? Because keep in mind that when I simplify the analysis, I'm mostly right, but not 100% right. Therefore, when I get a seizure like that, could it be a partially treated meningitis? Multiple antibiotics. What's your... Now I'm giving you a clue. I miscalculated my analysis and it was a bacterial infection. Okay, and by 1 month, he must have had another 2 sets of antibiotic wherever he went. But they must have taken it orally, so not working well. Will you debate whether it's a partially treated meningitis?
Child never had any symptoms of meningitis. The child should have been very toxic and headache and vomiting and...
So headache, vomiting is not there. What else?
Fever would have responded to some extent at least.
Okay. Anything else?
I'll give you a clue. At this age, it's an elderly child.
15-year-old.
How does a partially treated meningitis behave? Give a thought. I'm sure Nelson may not have given exactly in this word, but Nelson has put every damn thing in clinical medicine somewhere or the other. Give a thought. So what happens when it's partially treated? It's not completely treated, cured, nor it is just left to worsen the way normally untreated child goes or a drug-resistant child goes. What happens in between? The answer is he gets a localized infection like a brain abscess. Okay. He will not be, if first thing is that meningitis at that age is not encephalitis. It's only meningitis. And do you think meningitis gets a seizure? What do you think? Does meningitis get a seizure?
So is there an age difference as to which age meningitis gets a seizure? More likely? Younger age is more likely.
So meningitis has to involve the brain cell to cause a seizure. Otherwise it won't. Okay. A pleural disease by itself cannot involve the lung and worsen. Okay, and therefore meningitis in that age has to get so terribly, wrongly, irrationally treated and allowed to get into trouble. Otherwise, he will end up with a brain abscess, but he may not end up with a encephalopathy. So we want to know here, 1 hour the seizure continued. Okay. And thereafter, this child has recovered completely. What does it mean? It was an acute symptomatic seizure. And acute symptomatic seizure came as a neurological symptom 1 month after the fever. So it is not the cause of fever, okay, by itself, but it's the pathology that has come up worsening. So either it was an infection that we missed and now immune complication, or it was never an infection at all. And therefore, even that seizure at the end of 1 month, any child who gets a seizure, imagine CNS infection, seizure comes very early in encephalitis. In meningitis, the seizure comes very early in early infancy or neonate. But in an older child, it does not come unless you have misfired your management totally and allowed to develop encephalopathy. Okay. Maybe raised ICT causing encephalopathy, whatever. But otherwise, seizure is uncommon in older children and adults with meningitis. Okay. Besides that, there would have been irritability. In her video tomorrow, you will hear that partially treated bacterial infection can present like this, but there are clues. Some cough, or it could be pneumonia. Some vomiting, off and on, irritability, meningitis. Okay, there are clues. The child did not have any clue at all. So this is not a seizure of infection also. This is a seizure of an immune and what? Encephalitis. Okay. Question is, why did encephalitis came later? So it is not an ADEM or one of those which we discussed in the last 2-3 times, but this is a complication which is immunological. What set off, we don't know at this point. I think what you have said is exactly coming, right? How important it is.
What was this episode? Decreased responsiveness, not answering questions, seeing some people around. What would that mean?
Psychiatric
Psychiatric manifestations. Okay. So now there is some event that has happened. So do you think it is related to that event? Death of another patient on the neighboring bed?
Could be a coincidence. Could be a coincidence.
Why do you think so? So what I would have done is I would have asked that these complaints lasted how long. So if it was very short lasting, it could be due to that fear of that event or whatever. But if they persisted after that, then it is like a kind of an encephalopathy. So then it might be related to the original illness only, if it is long lasting, not just that event. It was long lasting. So then it's related to the disease rather than that event. Then rashes. So what do you make out of these rashes?
We want to know the distribution of the rash and the.
There was like so they were all over the body, like on the hands and legs and face, but discrete and very small sized, hypopigmented.
So distribution is all over the body. So do you think this is some viral exanthem? Some viral infection with a rash?
The onset of rash was very late in the disease.
Correct. So it's after 1 month of the disease that there's a rash. So no question of it being a viral infection. So what is the next common cause of such rashes? So some immune mediated, it could even be vasculitis, or it could be an immune mediated rash, right? Okay, and then you have hair loss. So hair loss, here what would it suggest now that this story is building up? And in general, what does it suggest?
Immunological phenomenon. Immunological.
Okay. And in general, where else in pediatrics do you see hair loss? So post a major illness, so post a big infection from which a child is recovering, you do get a phase of hair loss, right? Okay, fine. So now
What do you make out of the very first line here? Investigated and started oral medication. 6 weeks of fever, seizure coming later, hospitalized, okay, intubated, got out, and then some oral medication. Have you seen anybody in ICU with an oral medication? Have you seen anybody sick in the hospital with oral medication? Then why oral medication? What is your thought? Just give a thought. See, the point I'm making is that make a note of every small thing and find out whether it tells you something different. Okay. I'm sure you agree that somebody who has just come out of intubation would be possibly the next 1 week on IV antibiotics, which will give him another infection, drug resistant, and get on to another antibiotic. And this fellow is on oral medication.
Steroid was instead.
And more important is, they must have thought that he is already improving partially. Otherwise, they would have given some IV, okay, a pulse. No, oral is enough. Okay. So many clues you are getting on that, right? Yeah.
Okay. Now you want to sum up your diagnosis?
Summarizing it as a 15-year-old girl with a previous history of alopecia and rashes, now presenting with persistent non-infectious fever with generalized fatigue, loss of appetite, weight loss, and new onset epilepsy and neurobehavioral issues since the last 2 months in an otherwise developmentally normal girl, suggestive of some subacute to chronic inflammatory condition. My DDs are lupus or autoimmune encephalitis or TBM.
Okay. Very nice summary, Manas. So you've used a lot of adjectives and you've described the process rather than repeating the complaints. So that is what we should be doing every time. We should be talking about the process, right? Very good. Go on. On exam.
I think I like the best word you have used is neurobehavioral issue. Okay. Many times the SLE may present only with behavior abnormalities, and then a day, a week or a month later you start getting all other butterfly rash, etc. But see the word that is using, neurobehavioral issue, excellent. I think that's a wonderful way of putting up that episode when you said somebody died next week. That was the neurobehavioral issue, again related to the same autoimmune disorder, and straight away you would put SLE on the top with 15-year-old and girl. Excellent. I think very well made, isn't it? I think for all of us to learn how to summarize, just 4 lines in which there are 6 or 8 adjectives and very chosen words. Right? Excellent. Very good.
Thank you, sir. So, on examination, child was afebrile, heart rate 89 per minute with normal rhythm and rate, respiratory rate 18 cycles per minute, saturation was normal, BP was 90/50 on admission, no dehydration, hypopigmented macules present all over the body, and pallor was present, oral thrush was present, no icterus or edema, clubbing, cyanosis, lymphadenopathy, rest head to examination normal, anthropometry wise also it was normal. C and his examination, the child examined in supine position with hands lying by the side and lower limb semi-flexed. GCS wise E4, V1, M5. Tone upper limbs were normal but lower limbs were hypotonic. Upper limbs power was 4 by 5 and lower limbs, all the hip flexors, extensors, abductors, adductors, they were 3 by 5 on the both right and left lower limbs. The deep tendon reflexes, upper limb reflexes were normal 2 plus, but lower limb reflexes, knee jerks were absent and ankle was 1 plus. Plantars bilateral extensor, sensory examination normal, gait swaying towards right side, other cerebellar signs were normal and other system examination was also normal.
Okay, so how will you interpret your signs?
So
You have some
This is-
weakness, right?
yes sir.
So, what is it? Is it a paraparesis? Is it a quadriparesis? What is it?
It's a paraparesis, hypotonia is there, and the power is also less 3 by 5. Localization,
So, paraparesis with hypotonia. So, is it a LMN lesion?
could be sir, and UMN so it's not there, LMN possibly sir.
No, remember that when you are talking of paraparesis, it becomes a little tricky. When you are saying LMN, LMN means anterior horn cell or nerve root or peripheral nerve,
nerves,
muscle,
muscles.
etc. So here we are not thinking of that kind of a disease, are we? So what are your other signs? Your reflexes are?
The knee jerk was absent and ankles were 1 plus.
So reflexes are also less.
Yes.
So that also favors a LMN lesion. But what goes against a LMN lesion?
Plantars sir.
Plantar extensor, right? So you'll have to think whether this is a UMN lesion but in some kind of spinal shock, right? Because it's difficult to explain it as a LMN lesion, so nicely symmetrical and equal on both sides, right? What about the gait?
Only she was just swaying towards the right side. Yeah.
So interpretation, is it due to the weakness?
But sir, both lower limbs weakness is there. So right side particularly.
Correct. So two things here, that power grade 4, she should have been able to walk reasonably without swaying. But power grade 3, even the power can make them not able to walk much. But the difference is then not able to walk rather than sway. And why sway on one side? So therefore this again takes you away from power being a reason to possibly cerebellar involvement, right?
Okay.
That is the cause of the swaying. Okay, fine. So now in terms of signs, how will you, what all have you got? You've got possibly UMN paraparesis,
With
then
some also lower motor neurons signs are.
okay, so if you are saying lower motor neuron, then where will you put the pathology as? You think it's a polyneuritis? Peripheral
those
neuropathy.
spinal cord lesions, I don't think so. Could be uh, uh,
So, okay, so we'll discuss that, but otherwise you've got cerebellar signs and you've got these motor signs, which we are not sure whether they are upper motor neuron or lower motor neuron. I am more in favorable of calling it upper motor neuron rather than lower motor. But you got two different areas of the CNS being involved on examination, right? So multifocal pathology or multifocal signs. And then you had a GCS which was about 10, right? So which is also a sign of encephalopathy, generalized encephalopathy, correct? So those are your localization on examination.
I think there's no question of lower motor neuron here. It has to be upper motor neuron clearly. We don't have to look for in addition lower motor neuron. Okay, why do we do that? That lower motor neuron has a significant paresis. This is a mild paresis. Okay, there is a tone which he has already said is an acute insult, so hypotonia, but plantar extensor and a power not much lost. Okay, doubtful in the lower limbs. So we have an upper motor neuron only, no lower motor neuron. And there is a generalized disease, behavioral change. So how do you explain the lower limbs involvement, upper limbs probably not? Okay, is it a spinal cord upper motor neuron? The answer is to me no. Okay, acute onset would have also caused some bladder bowel, etc. Okay, some signs below and some signs at the level, and therefore this probably is a frontal lobe involvement bilaterally, where there is a behavioral issue as well. Okay, and a typical bilateral frontal pathology where upper motor neurons are involved both sides. Okay, it's a diffuse, it's not localized. It's certainly not subcortical, there is nothing happening subcortically, there is nothing internal capsule, nothing lower down. So it has to be brain, and mainly in the lower limbs. So bilateral frontal involvement. When it comes to cerebellum, yes, doubtful, because when he is having a mild weakness and therefore he is just recovering, so he could be swaying a little, but we will keep on watch closely, and he has already said no cerebellar sign. So the final impression on these signs is, these signs suggest a diffuse bilateral frontal lobe lesion. Okay, and I think that will be the analysis, and no lower motor neuron at all.
Last time there was a similar case and we had analyzed lower motor and upper motor. In the beginning we favored lower motor. On rethinking, I thought that if there is a lower motor neuron pair, he should not be able to stand only. If he is standing, that means the power is reasonable. He was able to move against gravity, and did not stand will not occur. So if somebody is able to stand, whether he is swaying or otherwise, lower motor neuron is out. It has to be upper motor.
Okay, final diagnosis.
15-year-old female child with history suggestive of a chronic inflammatory condition, with on examination pallor, hypopigmented macules, and on examination bilateral lower limb hypotonia, slightly reduced power, absent reflexes, without any sensory and cranial nerve. A cerebellar sign is there. So now it is more likely a upper motor neuron pathology with bilateral frontal lobe involvement, and pathology mostly some immune mediated process. The most likely differential is systemic lupus.
Investigations.
These were the outside investigations, where the counts were pancytopenic with low HB, low WBC counts, and thrombocytopenia. The OTPT levels were also high. SGOT was 305, SGPT was 84. Workup for SLE was done where C3 complement levels were low, C4 complement levels were normal, ANA was 4 plus with a speckled pattern, and SMD1 and SNRNP was strong positive. CSF was normal and MRI showed mild, fairly symmetrical flare hyperintensities in bilateral basal ganglia, thalami, insular cortex and medial temporal region. These were all the positive investigations when she was admitted here. HB was 8, WBC 2200, platelets 1.85 lakh, ESR was raised, SGOT 62, SGPT 222. The gamma GT was also slightly raised. DCT was weak positive. Her sodium levels were low to 124, for which 3% NaCl correction was given, and later on the sodium improved on salt sachets. ANA showed speckled pattern. The anti-Smith antibodies, anti-RNP were 3 plus, and anti-SSB and anti-Jo1 were borderline. C3 in our hospital it was also low. C4 levels were normal. We did a UPCR which was which was 2.3. ACLA was negative. We did a nerve conduction studies which showed pure motor demyelinating peripheral neuropathy. Because of the high UPCR, we did a kidney biopsy which showed class 1 nephritis, for which we treated her with initially, when she came with the neuropsychiatric condition, we gave her pulse MPS for 3 days and continued on oral steroids, started on oral HCQ, hydroxychloroquine. The enzymes went on increasing, so we hold the HCQ, and after the and we planned for IV rituximab after the kidney biopsy.
Just 2 questions. One, why ASR is so normal? And why kidney biopsy? What do you think must be the reason? Okay, there's nothing to suggest kidney, yes. See, clinically we would have said, yes, encephalitis, okay, plus minus other areas, like he said cerebellum, he put up even peripheral nerve, that's fine. But that peripheral nerve was not seen clinically as much as it is seen by the MRI, which is fine. And many times the MRI shows structural changes, whereas we are looking at a functional component clinically. So it's not rare to see much disseminated lesion on MRI, but a clinical story does not fit in everywhere. And you must have seen many neurology patients at Hinduja where 2 things don't correlate at all, but broadly yes. But my question is, would you have done a kidney biopsy? The patient would ask, why, what are you doing? Okay, what's your... Yes. And the justification is, in every SLA, if the presentation is only skin, mucous membrane and joint, you may not do kidney biopsy, but moment it has gone on to any other organ, you must find out, and there is a chance that multiple organs are involved. But if it's skin and mucous membrane and joints are never major issues, that is peripheral. Okay, but moment you get any one organ, even apparently normal kidney functions, you will look at everything possible. And kidney is one of the important things. Besides, kidney decides the prognosis. And that is far more important, to pick up early stage of a kidney involvement, and they have picked up grade 1 disease already. So they could possibly save the kidney from worsening, knowing that they need an aggressive therapy, right? I don't know why ASR is normal, which only means that the acuity of inflammation seems to be dying out, or it could have been done after steroid. They might have had given steroid earlier, we have no idea. But would you would you expect ASR to be normal? And it could be that they could have done CRP and CRP would have been high. In rheumatology, all rheumatologists do both. Do you think that's the reason that normally CRP is done even for 1 day of fever, ASR and CRP, and in this trial you have done only ASR? Do you think CRP would have been higher? No. In fact, ASR had to be high, but CRP. And why is that? Why CRP is low in SLE?
Where is CRP produced?
Liver.
Antibodies against many things. Okay. And which is a condition where ASR is low but the CRP is high. I'll give you a clue where fibrinogen is low. Because ASR depends on fibrinogen. And fibrinogen is low in something of similar kind happening in HLH. So HLH, ASR is low, CRP is high. And in SLE, CRP is low, ASR high. These are the two conditions where you will do ASR and CRP both. Otherwise, I don't see why you should do both at all.
This WBC count is okay for SLE? What is the normal WBC count in SLE? So it is either low normal or subnormal like this. Suppose it is high. Does it rule out SLE? So it indicates a infection, a bacterial infection. So if you are looking at a child in other parameters SLE and you get a higher count, think of a occult infection somewhere. Okay?
Good. Well presented. Very well presented. Okay. Only in your summary, because you put up earlier neuro behavior, you could have put encephalopathy also. But you have done very well. I appreciate that.
Thank you, sir.
Sir.
While I was going through the history in the beginning, I was also thinking of tuberculous meningitis with tuberculoma. How did we clinically come to the diagnosis of SLE and not tuberculosis we didn't entertain as either first or second one?
Actually, prolonged fever without localization in TB is possibly a miliary TB, where you are missing a localization in the form of a mild tachypnea. But that is not often complained of. So the history of 1 month of fever in TB without any other symptom whatsoever, not even cough, okay, could be miliary. And why malaria has no cough? It's a respiratory disease. Whereas rest all TB, largely chest, have a cough. How severe, whatever, that's different. But cough is a area where you start looking at a respiratory problem. So why does a miliary not have cough? And therefore, miliary is an interstitial lung disease. And as you go down the airway into smaller and smaller airways, the cough disappears, and that's why your acute bronchiolitis often does not have much cough but only breathlessness. And therefore, miliary could be one who can come with prolonged fever. No, the tuberculoma will not present with fever mostly unless it is meningitis with tuberculoma. And tuberculoma will present with a happy normal child, suddenly a focal seizure. And you know, neurocystic circus and tuberculoma come closer. And if it's a tuberculoma in a tuberculous meningitis, then he has already a meningitis. And don't forget that TBM is a TB meningoencephalitis. So there is irritability, lethargy, vomiting, okay, seizure early in the course. Okay. And if a 15-year-old child is going to develop meningitis, then this child has failed to control a lung TB there only. So there is a reason why it must have done. Okay. So either the earlier situation of low-grade fever, not doing well, loss of appetite, loss of weight was missed. And then during adolescence, puberty, that might have fared up. If this was not accompanied with a previous story, acute TB meningitis also may occur in an adolescence, but that would be suddenly flare up with an acute meningoencephalitis. So that's why not. In fact, he put up in his differential diagnosis TB unlikely, he said. And therefore, unlocalized TB is only miliary. And very soon then that also will localize somewhere, but it can go on for a month. The rest of the time, cough is a seizure. If it's a disseminated liver and spleen are features, okay. So possibly not TBM, right? And TBM, typically TBM in an older child is meningitis more than encephalitis. And therefore the story is not a seizure again. The story is to begin with vomiting, headache, etc. and then slowly drowsiness indicating that it's a meningoencephalitis.
But not just a tuberculoma without meningitis, sir?
Tuberculoma without meningitis is a localized disease, does not usually cause even fever, and the first symptom is a focal seizure. Okay, most of the tuberculomas are happy children who suddenly throw up a focal seizure, and you pick up because of focal seizure and neuroimaging, and then you start fighting between neurocystic circus and TB. So possibly not, right?
Could Wilson's be a closed differential?
Wilson's in this first
in this
child.
Based
So
on
if you only take the neurobehavioral issues, all that in an older child, yeah, Wilson's is a differential. But you never get 1 month of fever in Wilson's, the first month of fever. And secondly, you don't get that kind of a prolonged seizure. Means even if you were to get a seizure in Wilson's, it would be like a typical usual seizure, if you get. So it is more of neurobehavioral. So the order will be reversed. Your chief complaint was 1 month of fever, then second was one big seizure, and third was neurobehavioral. In Wilson's, only the third part may have been possible. First two are not possible.
Occasionally, 1 month of fever without localization, but would get a history of generally abdominal distension because of liver and spleen. But that may be overlooked. But there is no cough, vomiting, diarrhea, etc. 1 month of fever, and then suddenly throwing up a seizure is a complication of an infection which presents with liver and spleen only, and that is rarely a symptom. Okay, unless the parents have observed abdominal distension. And that can happen in a brucellosis and neurobrucellosis. Okay, this is just to complete all kinds of situation. Had it been a leptospira, within a week or so, the immune complications, more often liver, kidney, of course brain as well, but not over a month or so. Rickettsia, same thing, short duration of fever and complication. What about EB virus? Fever for a long time, but some ulcers, mouth, etc., and no complication. What about CMV in an immunocompromised? Quick one organ involvement and not just prolonged fever without any clue. So look at chronic viral, chronic bacterial endocarditis, for example. No neurological complication, only local. And therefore, possibly not TB as well. But brucella is one thing that you keep in mind when fever is the only thing, and you get a multiple small abscesses, okay, and the only differential diagnosis at that time is the histiocytosis, okay, which look like again same liver, spleen, fever, etc.
Come, we'll have the second case.
In an exam, if you would have said also the peripheral nerve, if I was the examiner, I would have asked you which of the supervisor has told you this. Because clinically you have no easy way to go by that. And therefore, I think even if you come to know through supervisor the diagnosis, you totally hide that information to the... And if there is some doubt, and he says, what about motor nerve? He says, I don't think so. It could be, but I'm not sure. Okay. So sometimes you know where is to bluff rightly and not use it. Okay. Because many times the parents or even the child 15-year-old, क्या होता है ऐसे ही हुआ है. She might tell you that in an exam. You say ऐसा मत बोलो, फिर पहले बताओ क्या हुआ है मत बोलो, क्या क्या होता है बताओ. Okay. But if you say history given, she says she has an SLE. No, that is not right. You hear and don't talk about it. So, no motor nerve, which you cannot easily go by, right? Medicine is so wide, no? We confidently said no lower motor neuron because the power is not so big.
गेल्या वेळेला आपण सर चुकलो होतो.
ओके, आणि उलटं झालं.
पण त्यावेळेला लेसन हाच घेतला होता की जर लोअर मोटर गेला तर तो उभा राहताच कामा. यावेळेला सुद्धा दॅट मीन्स वॉट यू वॉन्टेड टू से इज विल आयसोलेटेड tuberculoma, a happy child will get a focal seizure. And if it is tuberculoma with meningitis signs will dominate first.
Dominate, and tuberculoma often seen on neuroimaging.
So there is a technical problem. The slides cannot be projected on this. So he is going to read out the case slowly and loudly for us to hear.
Good evening all. My name is Dr. Pradeep Rajput. I am presenting short case today. 10 years old male child, born of non-conscious marriage, first birth by order, hailing from Wada Bhiwandi, resident of Vikroli, Mumbai, Ahire by community, Hindu by religion, was brought and informed by mother with chief complaint of abdominal distension.
Little slow and loud. Chief, how old you said?
10 years old male.
10-year-old, chief complaint of?
Chief complaint of abdominal distension since 1.5 months. Fever since 4 days. Cough since 4 days. The child was apparently alright 1.5 months back when he had abdominal trauma due to cricket ball while playing, after which mother noticed abdominal distension which was localized more on the left side, progressive, no waxing and waning course, and extending downwards, associated with early satiety and intermittent abdominal pain aggravating by coughing. Child was taken to private practitioner where USG was done and some medications given, but there was no improvement. Fever was mild to moderate grade, documented around 100 degree Fahrenheit, not associated with rash or chills, intermittent, subsided on local medications. Child was active during interfebrile period. Cough was dry, non-spasmodic, non-paroxysmal, non-productive, not associated with post-osseo vomiting. There was no history of loose stools or vomiting, no history of blood in stool, melena or hemoptysis, no history of blood transfusion in the past, no history of paleness or easy fatigability, no history of yellowish discoloration of sclera or high colored urine. There was no history of joint pain, bone pain, weight loss, no history of any other swelling, no history of any bleeding manifestations, no history of COX or COX contact. On past history, there was no history of any past hospitalization or any similar complaints in the past. ANC and birth-wise, ANC was uneventful. Birth-wise, full term, it was full term normal vaginal delivery. Birth weight was 3.5 kg and no NICU stay. Immunization was, child was immunized till 5 years as per national immunization schedule. Developmentally, he is normal for age. Dietary wise, he consumes from all food groups equally, consumes some mixed diet. There was a calorie deficit of 340 calorie and protein deficit of 5 gram. family and socio-economic history wise, status is upper middle socio-economic class. My impression is 10 years old male child on the basis.
Wait. Come, sit here. So the chief complaint is abdominal distension since 1.5 months, and after a cricket ball injury, mother noticed a lump in the left half of the abdomen which was progressively increasing. Correct? So now start. Tell us, what do you think? Cricket ball induced encapsulated hematoma. Yes?
Patient would have been hemodynamically
Very
unstable.
good. So out of question, there is not a hematoma. So what is it? Lump on left side of abdomen, what all could it be? One is spleen. Then could be kidney. It has to be a huge lump for it to be kidney. Anything else? Can it be a lymph node or any other mass? So theoretically possible, but most likely it is the spleen. Okay? What is the relation of the cricket ball injury? Has it caused the lump? It was noticed because of the injury, right? So we'll leave the injury aside. So now suppose it is a spleen, then progressive, he said, so progressive spleen enlargement in a 10-year-old boy. When did the fever start?
Since last 4 days.
Last 4 days. So for first 1.5 months there was no fever, only lump was there.
No.
So asymptomatic progressive splenic enlargement for 1.5 months in a 10-year-old boy.
EHPVO could be the first.
Okay, so EHPVO. We'll list and then we will debate and discuss further. So EHPVO, then?
Hemolytic diseases also we have.
Hemolytic disease. So which hemolytic disease? Can it be thal?
Spherocytosis.
Spherocytosis. So if it is hemolytic disease, it is spherocytosis. It can't.
Thalassemia भी हो सकता है.
Thal भी हो सकता है.
हाँ.
Okay. So anyone wants to discuss which hemolytic? Then we'll discuss between these DDs also. You agree thal हो सकता है?
If thal major, then obviously multiple transfusions and pallor could have been observed initially at 10 years.
So was this child asymptomatic for the last 10 years? No complaints. So for that reason, thal is ruled out.
Non-transfusion dependent thals can thalassemia minor.
Non-transfusion dependent thal. So what are the points against that? So why are they non-transfusion dependent?
Because there is some form of activity, beta activity.
That is one reason. And second?
The body is adjusted, compensated.
So there is some extramedullary hematopoiesis happening. Where does that happen?
Axial
marrow and liver. So there has to be a generalized abdominal distension and not just a left-sided. And then coming for the first time at 10 years is less likely. So thal is out. Okay? Any other? Which infection? Good to think, then we'll debate amongst them. So which infection? Chronic malaria. Okay. So chronic malaria, Kala Azar. So that is one infection group. Any other?
Splenic cysts, but
Splenic cyst. Okay. Any other? EBV. Okay. Okay. Any other category? So, malignancy. Okay. So which malignancy? Leukemia? Hodgkin's? Okay. So in Hodgkin's, what else will happen?
Lymphadenopathy.
Lymphadenopathy. Okay. Then, so now you have all these 4 or 5 groups. Now, take an example from the first case, which he summarized, and he gave adjectives. So, put adjectives to this 1.5 month story. What are the adjectives you will put? Okay, 1 is incidentally noticed. 2, progressive. 3,
Not associated with pain. Non-tender.
non-tender. Expand that non-tender. So it's not tender. Tenderness is what? It's a sign of inflammation. So do you have any other signs of inflammation? Do you have any other sign of dysfunction? Do you have pallor, icterus, anything? So you will call it what? Non-inflammatory and asymptomatic. So now start adding asymptomatic, progressive, splenomegaly, non-inflammatory you already said, incidentally noticed, and progressed over what length of time? 1.5 months that we know. Uske pehle how much it was we don't know. So just by using these adjectives, which of your DDs are out? Which you said. So infection, sometimes though you want fever, so out. Now maybe you can argue tropical splenomegaly, we'll see, as part of chronic malaria. Then what about EHPVO? By now he should have had hematemesis once, and also the age group is a little higher. They would have come up earlier. What about hereditary spherocytosis?
Should have come with some other, like jaundice or...
So sometimes the jaundice is noticed by us. But if you are asked that hereditary spherocytosis has mild splenomegaly, moderate or big, what would you say? It's not big, it is moderate often, maybe sometimes even lesser, right? Okay. So if you have to decide the pathology in this child, what would you put it? We said non-inflammatory. What pathology would you put? Is it degeneration? No. What is it? Non-inflammatory takes away a big chunk. So what is the pathology here? If something is increasing in size without causing any trouble, infiltration, excellent, right? So that's what you narrow down.
I think add 2 more features. One is short stature. Okay, all chronic hemolytic anemias have short stature. If they have never had treatment, anemia is going on, moderate, spleen is enlarging, no short stature. That would be an additional thing, which not only rules out a chronic hemolytic anemia, but also rules out another disease which exactly comes like that, and that is Gaucher's storage. Okay, till it starts with neurological symptoms or bone marrow symptoms, you can have just a splenomegaly. But again, they're not growing well, okay, and therefore storage, after all you said infiltration, that is storage. What all can be stored in the spleen? One is just a hyperplasia because of anemia, but it would have been a short stature. Same thing, metabolic disorder, short stature. Often not doing well even in terms of weight, but no other symptoms. Okay. Chronic myeloid leukemia, no other symptoms, growth normal, apparently appetite okay, not going down, and not much of pallor. So that could be still a possibility. Okay, and therefore we'll, like she said, cyst, yes, space occupying lesion, which is benign kind of. So add one more factor, no family history of consanguinity. Okay, what is spherocytosis? Autosomal dominant. How do you know in the history? One of the parents are short. They may not know that they have anemia, they may not know that they have, but they are short. And this child is also short, and both have spleen. So in an exam, when you get a spleen like this, okay, you could ask the examiner, can I examine the mother or father who is along? You will get straight away 5 more marks. Why do you want to examine the parent? Yes, I want to see whether it's an autosomal dominant disorder. Okay, and I think that's why we stay with all this. Occasionally, even the venous congestion may remain without hematemesis by luck. It's not that he must kind of have a hematemesis. And therefore, lastly, could it be a tropical splenomegaly? Again, symptom-free, growing reasonably all right. It's an immune complication of a malarial episode. So again, a past history. He may have been doing all right, but no past history of recurrent fever, okay, which will add to, say, less likely tropical splenomegaly. So I think add on all this, then only we will know which one you are talking about, right?
Okay, now tell us your differential and then examination. Loud.
10 years old male child, second birth by order, born of non-conscious marriage, birth and development in normal, completely immunized, with history of abdominal distension since last 1.5 months, with short history of fever and dry cough since 4 days, is most likely a case of infective etiology, EHPO, or neoplastic etiology, that is mass suggestive of lymphoma or renal tumors or neuroblastoma. On general examination, child was examined in lying down comfortably in supine position. Child was non-sick looking or febrile. Heart rate is around 110 per minute, normal in volume and rhythm. Respiratory rate is around 24 per minute. Saturation 99% on room air. Pulse peripheral pulses and central pulses well felt. Extremity is warm. BP is around 50 to 90 centile. Pallor is present. Cervical lymphadenopathy, multiple subcentric lymph nodes present in the cervical region at the level of 2, 3 and 4. That was firm and non-tender. Axillary and inguinal lymphadenopathy are also present. There was no ictus, cyanosis or clubbing, no bony tenderness. Anthropometrically, child is normal. On head-to-toe examination, well built, head normal in shape and size. Otherwise, no significant findings in head-to-toe except abdomen distension is there. On systemic examination, per abdomen examination, on inspection, abdomen distended, flanks not full, umbilicus displaced down and inverted, abdomen movements normal with no visible pulsation, with mild stage skin, with no visible dilated veins seen. On palpation, firm, non-reducing swelling with tenderness positive in left hypochondrium and left lumbar region, suggestive of massive splenomegaly. In right hypochondrium, liver size is 4 cm below subcostal margins. On percussion, dullness over left hypochondrium and lumbar region. Auscultation, normal bowel sounds heard. On respiratory examination, air entry bilaterally equal, mild wheeze present bilaterally. On CVS examination, S1, S2 heard, no murmur. On CNS examination, conscious oriented and tone power reflexes normal.
Okay, so you said massive spleen, 4 centimeters liver, small lymph nodes cervical, axillary nothing.
Axillary and inguinal lymph nodes are present.
Size?
Size subcentimeter, 1 centimeter.
Okay. And mild pallor.
Pallor is very mild.
And growth?
And normal.
Normal. Okay. So now what do you think out of all that we discussed? So does EHPVO still stand? Why not?
Hepatomegaly.
So EHPVO is out. What about hereditary spherocytosis?
Mild pallor is
Mild pallor is there, but what is not there?
jaundice.
Jaundice is not there, and stature, as sir just said, is normal growth. So that is also out. Okay? So now what are you thinking of now? How does it add to what we discussed on history?
So chronic liver disease, you have a hepatomegaly, you have a portal hypertension, straight off chronic liver disease.
Child was growing well.
So my question is, which chronic liver disease with portal hypertension grows well? You just picked up rightly, yes. And therefore he could have added no edema of feet, no loss of weight, etc. Yes. So which liver disease has a normal liver function but large liver and a portal hypertension, which is pre-sinusoidal, extrahepatic, no, intrahepatic. What you are talking about is extrahepatic portal obstruction, hypertension. I am talking about intrahepatic but pre-sinusoidal, where the liver is large, which is this disease. Congenital hepatic fibrosis. Looks like exactly HPV, okay, but there is a large liver. And it's only when there is a hematemesis occurring that a subtle abnormal liver functions, abnormality become manifest. So if you look at the liver function test in this child, and if it is a hepatic fibrosis, you will still find a mild rise in enzymes. There may not be low proteins, there may not be a bilirubin rise at all, but some enzyme rise is expected. But more than that, you need to look at something else, and which is another organ which is often accompanying congenital hepatic fibrosis, and that is kidney. So you must look carefully. Again, no symptoms. Okay, no symptoms whatsoever. And I think, therefore, keep in mind that, because we were not expecting liver, but we have a liver. So the question is, could it be a disseminated tuberculosis? Low-grade fever is being missed.
The child, it usually happens in an immunocompromised child. This is a well-growing child with no past history of infection.
Would not have been too asymptomatic. Any other disseminated infection or disseminated semi-malignant disorders like histiocytosis would not have done that. Okay. So to that extent, if your story is right, that he is totally asymptomatic, if your examination findings are right, that he is absolutely all right, except a very large spleen and a liver, then you are left behind with only whether there has been a congenital hepatic fibrosis as one possibility. If you talk of malaria, then why the liver again so much? Okay, otherwise chronic malaria with past history of fever but growing well is still possible with a large spleen, but not the large liver. And to that extent, are you sure that the liver is not pushed down?
No, sir. It was forced
So
to
the
Spanish.
other thing is that in a 10-year-old boy, he is saying axillary and inguinal lymph node also. Though he is saying they are small, but normally in a 10-year-old you wouldn't feel those lymph nodes.
Only thing is that if he is coming from an unhygienic situation in the lower socioeconomic group, the lymph nodes are everywhere. They are playing in the dirt, so inguinal are there. Okay, they are playing everywhere else. So if they are not large, in fact disseminated small, looks to be non-pathological. Okay, after all the illness should spread from one area to another, So like a Hodgkin's lymphoma, one big lymph node and then everywhere some lymph nodes, I can understand that. Or all big, I can understand that. But why all big, small? All why spread out but small? To me, that's possibly not significant. If you bring in those as significant, then you have histiocytosis as one possibility. Again, leukemia or Hodgkin doesn't come in because Hodgkin lymphoma starts at one area and spreads. And this is spread above diaphragm, below diaphragm, it is well spread. That is unlikely. No other kind of, could it be a sarcoid? No, not spread out like this. One area somewhere large, typically in the chest. So then of course you start thinking whether there is any other inflammatory disorders like Kikuchi and all that. But they are again one group of lymph nodes, not disseminated. So I personally feel that this must be insignificant lymph nodes and in a large liver and spleen. Because if you put all together, then it becomes very difficult to anticipate how he has been so fine, and his anthropometry is also fine. But we will have to look. You don't have a patient here, no? Or you have a patient? No.
There is general lymphadenopathy, but not significant.
Okay. Child is not here, no? Okay. Fine. So tell us your, investigation.
Can it be a chronic liver disease where it is not gone for complete decompensation? The liver is still in the hepatomegaly stage, and growth may not be so much affected in the child, and even Wilson's, is it possible in this particular, that do you have a chronic liver, in a chronic liver disease we can still have a hepatomegaly, it will need not be, and sometimes in Wilson's there may be not so much of affection of the growth, and therefore chronic liver disease with hepatosplenomegaly, portal hypertension, metabolic disease like Wilson's, the other manifestations, neurological, will come later. Whether that was also a possibility.
Actually, as an undergraduate, I'm sure you learned when there is a liver and spleen, is spleen bigger than the liver or liver bigger than the spleen? We talked about it. When you became a postgraduate, you said that's not often very helpful, but that is still. For example, a chronic liver disease, the liver is larger than the spleen. Okay, here spleen is larger. Then why am I talking about a chronic liver disease? So I'm talking about a chronic liver disease but not chronic hepatocyte disease. You get the difference? And then if it's not a hepatocyte disease, why is the liver enlarged? So the liver is enlarged because the fibrosis is occurring not in the hepatocyte but in the interstitial part of it. And that is compressing the sinusoids, and therefore the sinusoids which are going to the liver are getting compressed. That's why we call it a pre-sinusoidal but intrahepatic and not extrahepatic. And in an extrahepatic, the liver is not touched at all because the obstruction is outside the liver. Here, the obstruction is inside the liver, but still before the blood goes to the sinusoids and then to the hepatocytes. So you get the thing. That's why it is better. The EHPV, etc., was an earlier classification. Extrahepatic, intrahepatic, posthepatic. Now we talk about pre-sinusoidal, sinusoidal, and post-sinusoidal. And in pre-sinusoidal, extrahepatic, most common. Intrahepatic is hepatic fibrosis. Similarly, in the post-sinusoidal, you have extrahepatic post-sinusoidal. Which is that? Budd-Chiari. And which is intrahepatic post-sinusoidal? And that used to be earlier.
Veno-occlusive.
Very good, excellent, VOD. Okay, not much seen nowadays, but earlier some toxins used to cause that. So veno-occlusive disease, intrahepatic post-sinusoidal. Okay, very good. So I think that is the possibility. Of course, lymph node, etc. But in medicine, anything is possible. We will certainly investigate this child. We will not leave him alone, that's fine.
Tell us the investigations.
CBC wise, WBC is 1,69,000.
1,69,000.
Yes.
Okay.
Hemoglobin is 7.8. Hematocrit is 21%. Platelet is 6,57,000. There is a leukocytosis.
Platelets.
There is peripheral smear we have done. That was that shown blast cells up to 21%. There are leukocytosis. We have sent the bone marrow. We have done the bone marrow examination and sent for the flow cytometry leukemia panel. That was suggestive of CML. That was 3% of blast cells of myeloid phenotype. Smear suggestive of 3 to 4% blast increase in basophil myelocyte peak suggestive of CML CP. They advise BCR ABL1 mutation test and correlation with peripheral blood and bone marrow aspiration findings. We are planning for cytogenetics testing and further investigation and management.
CML. AML you said or CML?
CML.
I think we did say that to begin with, chronic myeloid leukemia can do that, but I thought lymph nodes, big liver, etc. looked little unusual and a totally asymptomatic child. Of course, everything is possible in clinical medicine, but I think what we want to be sure about is, I'm sure every time earlier, whenever Dr. Rajesh Udani would come on this, he would inquire with the mother the history again. And time and again he would find something different. Okay. So sometimes I'm a little afraid of myself that I would quote to say, I have seen such a patient, which is all wrong because there was something wrong in the data itself. So we need to be very careful about it. Okay. Because I'm sure in one of our clinics, there was a Wilson disease without a liver and without jaundice also. And still a Wilson liver disease. Now, that is difficult to understand. Okay, well, anything can happen, but nothing can happen to that extent that your statement, anything can happen, is possible. So what I mean is, we certainly take a call from this, that medicine is uncertain, but not, because we will remember that first. And that is a bigger disadvantage, right? So I think, please check on that, what the lymph nodes are like. Okay,
Sir,
whether they are really big, they are
He's saying lymph nodes are insignificant.
Insignificant, no. So that part is out. Okay. Then big liver, big spleen. I have not seen too many CMLs or so, but mainly they come with a spleen and not the liver. But I see why not the liver also, yes. And asymptomatic. I feel that quite fine, all right.
They have a huge spleen, not very anemic. This CML
typically has a normal CBC. Normal CBC. You have a 10 grams hemoglobin, you have normal WBC, normal platelets. Okay. And that I'm sure about. CML looks almost only spleen. And if you look at the undergraduate days, then you have malaria, CML, and ESPV. These are the common things. So,
chronic myelofibrosis.
yes, and that, but I'm sure congenital hepatic fibrosis is not so common. Maybe CML is a little more common than hepatic fibrosis. But when we saw the large liver, I thought first about the liver is involved. But I see that CML also could have a large liver, and of course the large spleen, which is quite typical. But good, I think...
Here we may add, of course, there need not be hematemesis to rule out a portal hypertension, because tomorrow he will have hematemesis. But absence of hematemesis, if we take a point against portal hypertension, then chronic liver disease, etc. would be... But that we can't say because he could still have a portal hypertension.
Only thing is that the typical chronic hepatic fibrosis, those small pre-sinusites are getting obstructed. So it takes time for that. When the large venous site gets obstructed, very early hematemesis comes, typically extrahepatic. And I have seen not too many, but few cases of the congenital hepatic fibrosis, where they are all little older children and they come with jaundice. Because that hematemesis puts a subclinical liver dysfunction to be manifest. But the history is, there was a little jaundice, but the jaundice disappeared within 4 days. That's kind of a history. And I recall on 2-3 occasions where it looked like a jaundice liver and that. But the jaundice came the last, even after hematemesis. And that said that you had a borderline bilirubin subclinical liver dysfunction which became manifest by hematemesis, by a large loss of blood, and a jaundice came, which was temporarily, and again the liver recovered quickly and the jaundice disappeared once the blood volume was taken care of. So I suppose that it could do that, but here there is a large liver and large spleen, so CML stands there, but I haven't seen too many CML, so big spleen is a CML. Yes.
Fine. Any other questions? Okay, thank you. So I think, yeah.
Could it be HIV, generalized lymphadenopathy, if we take that into consideration?
So I was also, for a moment it crossed my mind when he said generalized lymphadenopathy. But then as sir said, one is they are not significant, they are all small. Second is he's 10-year-old. So 10-year-old to come as generalized lymphadenopathy with hepatosplenomegaly as the first manifestation of HIV is less likely, right? So that is why.
And huge spleen.
And huge spleen.
In fact, the manifestation of a lymphadenopathy in HIV could be the first symptom before even CD4 goes down. And that is a symptom of a hypergammaglobulinemia. And when it starts spreading, then you get many symptoms. But I think that was a good thought you asked for that, right?
Anything else? Okay, fine. So I think we'll stop here and we meet once again next Thursday. Just a request, ये switch off कर दो.
Summarize first. 1-2 minutes.